We'll take the questions at the end. Next presenter is Dr. Zainab. Dr. Samad is Professor of Medicine and Chair Department of Medicine. She is a graduate of Khan University, class of 2000. She completed residency in internal medicine, a fellowship in cardiology, and masters in clinical research at Duke University. After completing training in 2009, she joined Duke University as a faculty, and she remained there till 2018 when she joined Khan University. Dr. Samad's clinical research efforts are focused on understanding the epidemiology and outcomes of heart diseases. Her mentorship and education efforts have been recognized with several awards. An important part of her professional vision is to improve cardiovascular health in Pakistan through gender-inclusive capacity building efforts that fully leverage available data resources and global connections. Dr. Samad will be talking about cardiovascular complications in COVID-19. Dr. Zainab.
Bismillahirrahmanirrahim. Assalamu alaikum, everybody. It's a real pleasure to be back again at on this series and give you a little bit of an update on this important topic in COVID-19. So I don't have any financial disclosures, and that it's reflected here in the slide. And really what I want to be able to do is help you all understand the risk of cardiovascular disease, or those with cardiovascular disease in COVID-19, learn about the cardiac complications of COVID-19, and then realize the impact of COVID-19 on global cardiovascular care. So similar to how we structured the talk, we're going to go through a couple of different questions. And some of these questions are repetition, but repetition is always a good way to remember things. What is COVID-19 and how are we affected? So I'm sure everybody knows by now that it belongs to a family of viruses called coronavirinae. And of these, a couple of them are actually endemic in our regions, and it causes common colds almost every year. And coronavirus, SARS-CoV-2, actually belongs to the beta family, and of these, there are three notorious ones. Obviously, this one is gaining far greater notoriety than the other ones, which is SARS coronavirus, first noted in 2002 to 2003, it caused an epidemic then. And then the MERS coronavirus that was started back in 2012. So these three viruses have caused severe acute respiratory syndromes and have had high case fatality rates. So the SARS coronavirus 2 actually binds to the ACE2 receptor, and then it is it's ingested inside the cell, and basically causes cellular destruction as that goes. The ACE2 receptor is found in different systems within the body, mostly the endothelium of vessels, respiratory epithelium, intestines, the heart, kidney. And so all of these organs are to some degree affected, some more than others in this almost syndrome. The incubation period is about 14 days, and about 50% of the people who develop this infection are asymptomatic. And of the ones who are symptomatic, most will have mild disease, and about 14% will have severe disease, where we consider things like hypoxia and 50% lung involvement. 5% will require critical care with respiratory failures and multi-organ dysfunction. So this slide, because this is the second series, I wanted to just reflect on where we were back in April when we did this. And at that point, the world has had about 3 million cases with 227,000 deaths. And now we are at 29 million cases with almost over 900,000 deaths reported worldwide. In Pakistan, the situation at the time we did the first series was we had 15,000 cases and 346 deaths reported. And now we have over 300,000 confirmed cases with 6,000 deaths. And we appear to have actually passed our surge and have come down in terms of the number of new cases. The observed case fatality rate for this illness is very different across different countries. And people who are wondering at that, it probably has to do with a couple of different factors. These include the demography of the country, what kind of infection mitigation measures they have taken, the level of health system support they have, and certainly some level of immunity offered by prior infections and chronic infections and so on. So coming to our topic, does the history of cardiovascular disease carry increased risk? And the answer to this is a resounding yes. So in a couple of different series that were initially published in the Lancet and New England Journal of Medicine, we noticed that a lot of the hospitalized patients actually have risk factors for cardiovascular disease or cardiovascular disease in itself. So out of this series that was initially published in the Lancet on a total of 191 patients, you can see that many of them, 30% had hypertension, 19% diabetes, and 8% had coronary artery disease. And these risk factors were more in people who did not survive versus those who survived. In this series of 393 patients admitted in New York, hospitalized patients, you can tell that they're older and that they also have high prevalence of risk factors, which includes obesity, diabetes, hypertension, and coronary artery disease. And so this is also reflective of the kind of demography each country has got. In Pakistan, we saw many younger patients with COVID-19. And the case fatality rate, it's important to sort of hone in on this important thing that the case fatality rate is maybe overall low, but for the individuals with pre-existing cardiovascular disease or diabetes or hypertension, it actually is high. Now, these are numbers published in a paper from JAMA, but probably not adjusted for age. Is there cardiac injury in COVID-19? So yes, if you looked at biomarkers, a lot of patients actually manifest or show evidence of cardiac injury, but they may not be symptomatic, and that's important to understand because you have to be able to go and treat symptoms and not just biomarkers. Those are good for prognostication, as we know people who have high or elevated troponin levels do worse than people who don't. But that's in terms of evaluating and risk stratifying the patient. It's known that 20-30% hospitalized patients have COVID-19 patients actually have some level or evidence of cardiac injury, and it's highly present amongst the individuals who died. Heart failure in 23% hospitalized patients, and arrhythmia in 16% hospitalized patients. These are from different references in literature so far. So, there has been recent controversy on two papers that came out in the last 2 to 3 months. And one of them was on a set on 26 competitive athletes who had COVID-19 infection. And of them, very few were actually symptomatic, and they underwent cardiac MRI. And what these people find, you can see on these cardiac MRI images, in the first, and in A and D that you can see that there is evidence of a pericardial effusion. In panel B and E, the pink and gold images, you can see that there's elevation of T2 that's suggestive of myocardial edema and seen in myocarditis. And then in C and panel F, you can see that there is delayed enhancement. So suggestive of the fact that there was about 15% of these actually had evidence of myocarditis, and about 30% had evidence of prior cardiac injury as manifested by late gadolinium enhancement. And that paper came on the heels of another one that actually showed, this was done out of Germany, about 100 individuals who had recently recovered from COVID-19, and this was an unselected cohort, so the MRIs were not done for a clinical indication, they were just recruited for this study. Cardiac magnetic resonance imaging actually showed that there was cardiac involvement on 78 patients, 78%, with ongoing myocardial inflammation in 60% individuals. And what they found was that this was independent of the pre-existing conditions, severity, and overall course of the acute illness, and at the time of the original diagnosis. High sensitivity troponin T values were detectable in 71 patients recently recovered from COVID-19. And compared with healthy controls and risk factor matched controls, patients who had recently recovered from COVID-19 had lower EF, lower left ventricular ejection fraction, lower right ventricular ejection fraction, raised native T1 and T2. These are, measures that suggest that there is inflammation, edema going on. And so this paper actually suggests that a lot of patients may have undetected cardiac involvement. They generated controversy because although we know what late gadolinium enhancement and these signs may suggest in other conditions, what their long-term prognosis or short-term prognosis might be, but in this particular disease, we don't know whether one, that these MRI findings were indeed causative from the COVID-19 infections, and two, what their long-term prognosis is, and how will that actually, knowing what we know, how does that change our management? So these findings are really interesting, but they have to be taken in the clinical context. So in terms of the mechanisms of cardiac injury, this is kind of what we thought. There are a couple of different things that you end up seeing. You see that there is evidence of cardiac injury by use of biomarkers like high sensitivity troponin. There are individuals manifest arrhythmias. Some individuals that we've seen acute coronary syndromes, either precipitated from hypoxia and the general systemic inflammation that goes on. Coronary dissections have also been seen in these situations, and then obviously there is a state of hypercoagulation that that precipitates thrombosis and so on. So there are a couple of different lines that can cause cardiac involvement, and that could be through hyperinflammation, increase the systemic inflammation, endothelitis. There can be direct myocardial injury, and then there is respiratory failure and hypoxia that precipitates it. This is from a recent Nature review in JAMA, in Nature Reviews of Cardiology, which kind of actually shows very nicely the bidirectional interaction between cardiovascular disease and COVID-19. You can see that the underlying comorbidities like hypertension, coronary heart disease, and diabetes actually precipitate risk or increased risk. And the injury can be seen in terms of a variety of different ways, whether you see increased troponin levels, myocarditis, acute coronary syndromes, arrhythmias, or thromboembolism with long-term effects over there. In addition, there are numerous drugs that individuals who are taking, who have prior coronary artery disease or new coronary artery disease and a COVID-19 infection, they interact with the drugs that have been tested or people are still using for risk mitigation in COVID-19. We all know that the disease actually, the COVID-19 infection has almost three phases. There's the viral response initially, there's a pulmonary phase with abnormal chest imaging, and then you've got hyperinflammation that actually takes people down, and which really has been the target for new therapies or new effective therapies, I must say. And it takes almost about 10 days for people to actually show up sick to the hospital. In that regard, how the group on imaging released some guidance in a couple of society-linked journals. And here you can see that a couple of different scenarios have been sketched out, and how would you go about evaluating individuals who've come in with either hemodynamic instability, new left ventricular dysfunction, or whether you're trying to understand whether somebody has acute coronary syndrome versus myocardial injuries related to COVID-19. So this is a nice paper. I would suggest you all look at it. But essentially, a good place to start when you're evaluating or trying to understand either hemodynamic instability or trying to differentiate between ACS versus diffuse myocardial injury seen in COVID. getting a point of care ultrasound is a good place to start. And then you have other modalities like coronary CTA that can actually help evaluate coronary arteries if there is someone with increased risk and symptoms that would push you one way or another, and a non-invasive method is preferred. Obviously, somebody with full-blown ACS must be treated the way you would normally treat ACS, with adequate protection of your healthcare workers and your staff. And at this point, a lot of cath labs have adapted and developed protocols as to how to protect the patient, how to protect their staff, and actually try and keep to the times required of timely revascularization in those situations. So what are our treatment options? Now, a lot of this is supportive. What you're going to do with heart failure is pretty much what you would do with heart failure without COVID-19. So you're going to try and do afterload reduction. You're going to try and relieve pulmonary congestion. And so those would be the principles that would still hold in this situation. But if it's ACS, you have to immediately revascularize the patient, especially with an ST elevation MI. And the same goes with arrhythmias. You have to stabilize the patient. And so your choice of drugs is the one that you need to just be careful about, and make sure that none of the drugs that you choose actually have direct interactions with other drugs that you may be using to take care of COVID-19 patients. So far for the COVID-19 patients, I had a long list that I'd shown in the last webinar, but here at this point, some of the mainstays that are being used is remdesivir, an antiviral drug developed actually for SARS. That's shown benefit. Dexamethasone has been shown to be fairly effective in individuals who are requiring oxygen, and so that's standard of care right now. And then we use anticoagulation because we found that this disease with this endothelitis, which is manifest all over in the forms of strokes, ACS, and PEs, and so on, that you have to actually do standard prophylaxis for everybody who gets admitted. And depending on D-dimer levels, you may want to go, or frank evidence of thrombosis, that you may want to go with full dose anticoagulations. Now, general considerations, I've touched upon this before, that there are cardiac side effects of investigational drugs. Now, thankfully, hydroxychloroquine and azithromycin are not used, but that was rather a difficult combination because both of them tend to prolong the QT interval. And then clearly there are drug-drug interactions, and as well as those with investigational drugs. Now, there was a question that a lot of people put forth, and people just didn't know which way to go, because this virus actually attaches to the ACE2 receptor, and so there was a lot of question about whether you should hold ACE inhibitors or ARBs, or should you restart them, or what should we do? So there was a first randomized trial actually that was just presented at the European Society of Cardiology meetings, the BRACE Corona trial, that shows that there's actually no difference. So for between discontinued and continued arms for this drug. As individuals who have clear indications, which is why they're already on the drug, should not have the drug discontinued. And if they have clear indications, for example, new onset heart failure, and so on, they really should get on the ACE inhibitors and ARBs. And the last part of my talk really touches on the fact that COVID-19 has had collateral damage as far as our normal care for cardiovascular disease patients is concerned. So we have a large outpatient setting where people come in, they've got secondary prevention regimens going on, they require follow-ups. The individuals who are coming with new symptoms. Given the lockdowns, the fear, and so on, a lot of those people just sat at home. They didn't do follow-up, they did not come in, even for emergency care. And this is what we found in a very large survey that was actually spearheaded by the European Society of Cardiology, and that included over 3,000 participants in 141 countries, over 6 continents, showed that about 78% of respondents perceived a decrease in the number of STEMIs, ST elevation MIs, coming into their hospitals. And 62% of the respondents declared that STEMI patients presented later than usual. So they were coming in 3 or 4 days later, many hours later than they would have normally presented, beyond the window that we require to use PCR thrombolysis. And then a lot of the cardiologists and staff and others involved in the survey felt that that cardiologist departments had partially or totally restructured to accommodate infected patients. So this is a big thing, right? One must, and I hope that our participants who are patients also are watching this video, it is important to know that at the end of the day, the chance of dying of an untreated heart attack is far greater than the chance of dying from a COVID-19 infection. So if somebody is having symptoms, they must absolutely seek emergency care in a very timely fashion. Okay, so that's a really important important point. Please, if there is symptoms of a heart attack, if there is a heart attack, the chance of someone dying of that is far greater than them dying of a COVID-19 infection. So that's something that as a cardiology community, we need to be raising more awareness around and making sure that these patients actually have appropriate access to care and are coming into the hospital in a timely fashion. So in summary, cardiovascular disease is very common amongst hospitalized patients. The CFR for COVID-19, the case fatality rate for COVID-19 among CVD patients is higher. Cardiac injury associated actually increases the chance of death. Supportive care, guideline-directed medical therapy is what you would do for all of these patients. And then remdesivir and dexamethasone seem to be sort of the standard of care for the COVID-19 aspect of disease. And many other drugs are in pipeline and being tested, so please stay tuned in this and watch out this space. Thank you very much for your attention.
Thank you so much, Dr. Samad.